Good afternoon, everyone, and welcome to the Maternal Health Echo, which is brought to you by the Center for Substance Use Training and Telementoring Center, or CSTAT, at Be Well, Texas, in collaboration with the Perinatal Psychiatry Access Network, or PeriPAN. My name is Brenda Macias, and I'm today's facilitator. To help us with attendance, please type your name, affiliation, and email address into the chat. To access the chat feature, you can click on the speech bubble icon on the navigation bar at the bottom of your window. And if you're joining via phone, please email your phone number and name to cstat@uthscsa.edu. We hope you'll join by video for the discussion portion in the latter half of the session, but no matter how you're joining us today, we're just happy that you're here to learn alongside us. We encourage everyone to unmute and share questions and comments aloud after the didactic, but we ask you to stay muted unless you're speaking. There are a lot of us in this space, so please keep your comments brief so that others can have the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or in our discussions. Our didactic today is on the trauma-informed care for pregnant and postpartum women and will be presented by Dr. Joy Subrin. Following that, we'll have a case discussion presented by, Miles Raisada. And then we'll start with introductions, followed by the didactic announcement and our case presentation. Thanks again for joining us today. We'll start with our introductions of our hub team members. Dr. Anastasia Ruiz.
Hi, everyone. I am a attending psychiatrist for the TTU HSC University Health System, and I am the regional director for our PeriPAM program. So I'm super excited to have you guys join today because we do have a lot of coverage on this topic on the perinatal population. And what I do in my clinic is I see a lot of pregnant and postpartum mothers, and this is such an important topic today. So thank you all for being here.
Thank you, Dr. Ruiz. Dr. Emily Humphrey.
Hello, my name is Emily Humphrey. I'm a doctorate of nursing practice, family nurse practitioner, and I've spent the past 12 years doing addiction medicine on the inpatient and outpatient side with the focus on women during that time. So happy to be here.
Thank you, Dr. Humphrey. Dr. Mohammed Chaudhry. We'll pause and wait for him. Dr. Purvanshi Alag.
Hi, I'm sorry my video is paused. I'm driving, but I'll join back very shortly. It's nice to be here as always. I'm one of the general and addiction trained psychiatrists, also have some skills in obesity medicine. I'm a specialist for that as well. Absolutely enjoy working with patients with substance use and mental health. I do a lot of outpatient with a dual diagnosis at Star Care, which is the MHMR, and at Texas Tech Outpatient, and also some of it at Student Wellness Center. Excited to be here. Looking forward to discussions today.
Thank you, Dr. Alag. And I've saved our final hub team member, Dr. Joy Subrin, for last because she is our presenter today. So I welcome all of our hub team members. I thank you for joining today's session. Dr. Subrin, we're glad to have you as a presenter. And I'll hand this over now to you for your introduction and for the presentation.
Okay, great. I'm going to share my screen in a moment, and I'm hoping everyone will give me some verbal confirmation that you can see and hear it. My name is Joy Subrin. I'm a licensed master of social work and a doctor in behavioral health. I'm embedded, very lucky, I'm embedded in an OBGYN practice, so we share patients in real time when women come in for OB or GYN care. And I've been in practice here 10 years and prior to here another 10 years, and I'm just really honored to share trauma-informed care principles, and I would love to hear your pearls of wisdom as well. So without further ado, I'm going to try to share my screen, so everybody hold on. Okay. For those of you who are here at our breakout session know that I had just a little bit of technical difficulties. Let's see. Can you see my screen or the presentation?
We can see it, but it's in the presenter mode.
Oh,
If
of
you
course
can
it is.
on display settings and then
Okay. Oh, how about that? Better? Better mode?
not yet.
Not yet.
Again, maybe.
So you seeing my present my notes on the,
Yes, we do.
okay. So let me try one other thing. Now I'm guessing you don't see anything.
Nothing at all.
Nothing at all. Okay.
Are you using PowerPoint?
Yes.
Okay, so if you'll go to the presentation mode and then share the application instead of a screen, that might be a little bit easier.
Yeah, that's what we practiced, I promise, folks. Okay, let me try again. Okay, I'm going to share, and I'm under application, and I am sharing. Oh, now it's so teeny tiny. I don't know if you can see it at all. Sorry, everybody. How about now? Do you see the slideshow?
Still seeing the notes page or the presentations.
Okay.
Swap presenter. There it is. Woohoo! We got it.
We made it, everybody.
Thank you.
Okay. All right. Sorry for that. That may happen again. That's where my traumatic memories are about presenting and having internet snafus. So without further ado, we'll go ahead and begin. As I said, I'm Joy Subrin, and I'm coming to you from the University of Arizona to talk about trauma-informed care for pregnant and postpartum women. So we'll start with our learning objectives. We're going to be defining trauma and distinguishing between various types of trauma, trauma levels of trauma, and the impact of trauma. We're going to be describing the 6 core principles of trauma-informed care and their relevance, the impact of trauma in perinatal period, and how we can apply the principles of trauma-informed care to support our patients. So this is a really special presentation, and I just want to pause for a moment, as I do with patients, and I'm sure you do, that the discussion of trauma can sometimes bring up memories or emotions related to your own personal experiences. So you may experience feelings of being uneasy, having some discomfort, feeling anger, and it's valid. So I just encourage you to take care of yourself during this brief 15 to 20 minute presentation. And this is what I say to patients, take a break, take a breath, and even step away if you need it. So that's my language, and I just want to share that with you. If something in this presentation is difficult, take a break, take a breath, take a moment. And just a small little quote, just a ripple spread out when a single pebble is dropped into the water. Oops. The actions of individuals can have far-reaching effects. Okay. So trauma-informed care, also some may use the term trauma-informed approach. It's a set of principles and approaches that realizes the widespread impact of trauma and understands the potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system of care, and responds by fully integrating knowledge about trauma into policies, procedures, practices, and we seek actively to resist re-traumatization. And trauma-informed care is not one size fits all. It's an approach to service delivery. It's our set of principles that guide us, that can shape the way that people interact with our organizations, with our patients, our clients, our stakeholders in our environment. So as I mentioned, one of our goals today is to talk about types of trauma. So first of all, one working description or definition of trauma: an emotional response to a terrible event or a series of events, such as an accident, a long-term series of events, sexual assault, or a natural disaster. SAMHSA describes individual trauma as an event or circumstance resulting in physical harm, emotional harm, or life-threatening harm. An event that affects the individual's functioning physically, socially, emotionally, and spiritually. And I'll share this diagram. So there are, the American Psychological Association outlines trauma into categories. So we have acute trauma, which is a single traumatic event. We have chronic trauma, the experience of multiple traumatic events. System-induced trauma, traumatic, for example, a traumatic removal from a home, admission to a detention center, residential center, facility. Complex trauma, this is both exposure to chronic trauma and the impact of such exposure has on a person. And then added to this list, but just outside the circle, will be secondary trauma. And this is a person develops trauma symptoms due to close contact with someone who has experienced a traumatic event or being continuously exposed to stories of trauma, hearing or reading about traumatic events. And I just wrote, for example, healthcare team and families. So trauma has no boundaries, regardless of age, gender, socioeconomic status, race, ethnicity, or sexual orientation. Trauma is a common experience for adults and children, and it is especially common in the lives of people with mental and substance use disorders. And just earlier today, a colleague friend of mine was saying, you're going to give this presentation and they're going to remember 3 things you say. So one of the things she said is, please go into the room assuming that your patient has one of those levels of trauma, and assume that they might have something from the ACE score, the adverse childhood experience. So to be sensitive to what might be hiding in clear sight. So I thought that was so valuable. I wanted to share that. Okay, so SAMHSA outlines the levels of trauma through this diagram. So we have individual trauma, family trauma, so individual being the micro level, and then the meso levels, and then the macro levels of trauma. And specifically for our topic today, we're going to be talking about trauma in women and then trauma in the perinatal period. So trauma in women, there's a higher prevalence of trauma. Women are nearly twice as likely as men to develop post-traumatic stress disorder. Women are more likely than men to experience certain types of trauma, such as sexual assault, intimate partner violence, and reproductive trauma. According to National Center for PTSD, approximately 8% of women will develop PTSD in their lifetime, compared to approximately 4% of men. Gender-based violence impacts women, of course, discrimination, racism, poverty, unequal access to care. There's health impacts of trauma in women. Trauma is linked to chronic pain, autoimmune conditions, depression, anxiety, substance use, and poor maternal outcomes, which we'll dedicate in another slide forward. And trauma often goes unrecognized. Many women may not disclose trauma unless directly asked. And that's such the importance of why we're here today, to talk about how we can ask, how we can help to recognize and honor and validate trauma in our patients. This short slide is dedicated to our topic today, trauma in perinatal period, either past or current. And it falls into 3 categories. So trauma for women in the perinatal period is unique. So we have obstetrical and reproductive trauma. This could be reliving or experiencing an emergency C-section or a birth complication. That sudden high-risk birth can lead to feelings of fear, helplessness, loss of control, that could persist into future pregnancies. There's perinatal, excuse me, a little frog, perinatal grief. This includes miscarriage, stillbirth, neonatal death, often followed by profound grief, isolation, or even anxiety about future pregnancies. And infertility journeys are unique to our patients here in the perinatal period. Health-related trauma, a negative healthcare experience. If a patient feels dismissed or unheard or disrespected in any way. There's also perinatal medical trauma or chronic illness, managing a serious health condition. And then there's the area of interpersonal and structural trauma, our patients who've experienced sexual violence or abuse or intimate partner violence. So these are additional 3 unique areas that women are affected by trauma and then even more highly affected during the perinatal period. You will get the copy of the slides, so I'm just going to review a few of these. So unique impacts of perinatal trauma, unique to the individual, so the woman you're caring for. She may have heightened fear, hypervigilance, dissociation during pregnancy, difficulty bonding in the postpartum period or during pregnancy. And unique to the families and children, there could be a strain on the partner relationship and intimacy and co-parenting and family communication, just increased family stress in general. We want to be aware of heightened risk of parental mental health conditions and addiction, both paternal and maternal. So it's a really unique time to be talking to our patients about trauma. And that's what trauma-informed care is all about. How can we open those conversations? So impacts of trauma are categorized into 7 areas by SAMHSA, and here they are. So we have impacts being emotional. Is your patient having difficulty regulating emotions? Is your patient having a behavioral impact? Maybe they have some self-destructive behaviors, substance use, avoidance. Is there a physical impact? Are they hyper-aroused? Are they having physical symptoms due to distress, like headaches, high blood pressure, fatigue? Is there a developmental issue or impact? We just are so sensitive and vulnerable to trauma. Is there a cognitive, interpersonal, spiritual impact? So trauma, as you can see, it has a layered effect on our patients. So just some important thoughts to remember. Mental health conditions are the leading cause of pregnancy-related deaths in the U.S., affecting women from pregnancy through the first year of postpartum. Just a side note that I think I've mentioned before, I co-host a maternal mental health support group, and we welcome women to come during and up to 1 year or a little bit after, and this is why. We want to keep supporting our patients. These include suicide risks, overdose-related risks, responsible for approximately 25% of maternal deaths, surpassing hemorrhage, heart cardiovascular disorders, and hypertensive disorders. So it's significant. Trauma, suicide, and overdose in our perinatal population. Trauma significantly increases the risk of perinatal mood and anxiety disorders. That's why I was talking about the support group and offering that tiered approach, that layered approach to care in that very first year. A significant risk to substance use and a significant risk to suicide and overdose during pregnancy and the postpartum period. Co-occurring conditions are common. Postpartum period is the highest risk, especially within that first year. I think I've said that a few times here on this slide. And missed opportunities. Many women who die from overdose had no prior treatment for substance use disorder. And I just want to call attention to this part. Prevention is possible. That's why we're sitting here today while we're learning together. We can improve screening. We can use trauma-informed care to help our patients. And we can help our patients gain access to mental health and addiction services. So our power is wide and tangible. And I just love that there's like 50 or more of us here today, because our voices matter and we're touching so many patients' lives to hopefully reduce some of these risks. So understanding trauma response comes in 3 categories. The trauma response can be mental, physical, behavioral. Most people experience a temporary reaction to trauma that resolves over time. Others may have prolonged or worsening symptoms, moving from acute distress to chronic, such as post-traumatic stress disorder, anxiety, substance use disorders, and mood disorders. Trauma can also lead to physical health problems. This is probably just 3 of many: arthritis, headaches, and chronic pain. You're probably thinking about patients that you've interacted with who've experienced physical health problems after trauma. Patients may display behavioral responses to trauma or a perceived trauma or perceived threat from past or present. Also often reflected in the 8 F's, and that's what we'll dedicate this slide to. I kind of jokingly say I'm old enough to remember when there were 3 F's: fight, flight, or freeze, and now there are 8. I can't see you, but maybe you're smiling. But it has grown. To know our patients is to recognize their symbols of trauma, their behavioral symbols. Are they freeze? Are they in flight? Are they in fight? Are they in freeze? Or are they in fawn, fold, flop, flight, or flag? So you're going to get a copy of this, but I encourage you to kind of get an idea of what that might look like for your patients if they're showing you a sign that they're having a memory or reflecting on a trauma. So with those 8 F's in mind, I'd like to just move forward into a brief case description and how the provider can influence this patient experience by using trauma-informed care, being aware of the 8 F's, and help this patient through this brief example. So a woman goes to the gynecologist for a routine prenatal care visit. After smoothly completing the intake with the medical assistant, the provider enters the room. The provider, meeting the patient for the first time, greets the patient, introduces themselves, explains the steps of the exam, and leaves space for the patient to verbally acknowledge and agree with the plan. The patient made eye contact, spoke clearly with the provider and directly, and kept their hands gently by their side. As the provider began the examination, the woman's voice began to tremble and soften. She stopped making eye contact with everyone in the room and turned her head to look at the door. Her hands clenched and her body seemed to brace for something that was unseen. Some providers may dismiss this behavior as standard nervousness, but often these are key behavioral signs displayed by a trauma survivor. The first step, which may happen automatically for the healthcare provider, is often to support their patient. This can be done by, number 1, recognizing it. That's our first skill, is we recognize the trauma response. And our second is to respond by offering regulation. And this is the sequence of engagement. Maybe you've seen it before. It's by Dr. Bruce Perry, and it flows upward. So first, after we recognize that we're sensing a shift in our patient's mood through mental, physical, or cognitive changes, which I think the example had all 3, we want to offer some support through the sequence of engagement. We're going to regulate with our patient, focus on helping the patient achieve a state of calm and stability through sensory regulation. We can also then move into the stage that's called relate, establish a connection, build a relationship crucial for emotional safety. And then we can enter the last sequence of engagement, which is reason. A cognitive reasoning can take place, allowing for problem solving, higher level of thinking, and moving the patient back into what we call the window of tolerance. You might be familiar with this. It's by Dr. Siegel. And I always make this shape with my hands. So sometimes our patients become hyper-aroused, hypo-aroused, and we want them right here, somewhere in the middle where they can tolerate. So we call that the window of tolerance. And you can do this with grounding activities, mindfulness, teaching the patient a deep breathing activity, sharing some words, like I'm here with you, I support you, let's take a break, just re-empowering the patient. So I find this sequence of engagement really helpful. And this might be happening in your exam rooms in a blink of an eye, but just for any newer learners, I think this is It's a helpful model, a helpful tool. So that engagement, just to pause, trauma experiences can alter a patient's sense of self and safety. This may lead to a fundamental disbelief that they don't belong or they are unsafe. By recognizing that traumatic experiences and their effects tie closely to behaviors, frontline professionals can begin to practice the 6 key principles of trauma-informed care across the continuum of care. So you might have seen this before, but trauma-informed care falls into these 6 principles. And we have a really neat slide on the next page, which will outline how we're going to use it with our patient from today.
Dr. Subrin, just wanted to give you a 5-minute warning.
Oh dear, I'm long-winded. I'll pick up the pace, everyone. 6 principles start with safety. Safety in the physical setting. Trustworthiness and transparency. Did we conduct this exchange with respect and fairness to build and maintain trust? Can we offer peer support through a traumatic experience or following? Can we partner with our patient to leverage our differences? Can we empower our patient to highlight her strengths? And objectivity is the organization moves beyond stereotypes and biases. So I want to, with time of the essence, in terms of our case. So our patient, did we notice her body language shift and her voice shift? Pause the exam, check in to ensure she feels emotionally and physically safe. That's safety. The next step, trustworthy. Continue clearly explaining each step and reassure the patient she can stop at any time. Maybe we need to reschedule. Maybe we just need a moment. Number 3, peer support. Offer follow-up resources like doula, prenatal groups, support networks for emotional support, collaboration. Invite her to make decisions, when to proceed, what the positioning is. Share power in this interaction. Empowerment, voice and choice. Offer choices throughout and objectivity. Be sensitive to possible past trauma, cultural factors. Ask respectful, open-ended questions as you continue your exam, your time with the patient. So this is just something that I experienced as a learner, and I would love if you participated with me. It's just the importance of our words and our language when we're speaking with patients who may have experienced a trauma. Our body interprets language through the lens. So these are some common phrases that can unintentionally evoke distress or defensiveness. So for you, if you could, reflect on what emotions and what physical sensations are happening for you today as I say these sentences. And you don't have to tell me. We'll be meeting alone today. So do you have a sensation in your body or in your mind? You failed. She refuses to get help. Your payment is due. This is urgent. Why did you just leave? Sorry, there's a typo. Why didn't you just leave the relationship? So I share those statements very commonly used in practice and a bundle more, and how they can unintentionally evoke distress. So we want to be really careful and conscious of our language, how we deliver information. In trauma-informed care, mindful language fosters safety, trust, and connection for both the patient and the professional. So recovery from trauma is not only possible, but it's expected. Post-traumatic growth is a well-researched concept by Dr. Richard Tedeschi and Dr. Lawrence Calhoun in the 90s. It's widely respected as a framework. It refers to the positive psychological changes experienced as a result of trauma. It's not about the trauma being good. It's about how people grow after trauma, not just recover. I find that pretty amazing. I think I like to share that with patients, that you're going to have post-traumatic growth in all of these areas. New possibilities, increased personal strength, enhanced relationships, appreciation, spiritual growth. These are just a few helpful readings, as I know I'm wrapping up my last 60 seconds. Books to keep in mind: The Body Keeps the Score, Invisible Heroes. And in summary, supporting patients in early recovery from trauma begins with education, a sense of safety in the treatment environment, an explanation of how trauma continues to impact their lives, like those 8 F's. And applying those principles of trauma-informed care, enhanced screening, assessment, strengthen treatment planning, reduces the risk of re-traumatization, and trauma-informed care emphasizes the healing power of safe, empathetic, and consistent connections between the provider and the patient. And this is my last note to you, and I was just practicing and preparing for today, and this song came to mind, and that our world is anything but ordinary, and the gifts you bring to your patients are extraordinary. So thank you for stepping into this world and partnering, and for your attention today. I have many, many, many references, and you will get these slides. I'll go ahead and stop sharing.
Thank you, Dr. Subrin. And I would like to ask all of our participants, if you have any questions, to drop those into the chat. I'd like to protect everyone's time and also our case presentation by having your questions go into the chat. Dr. Subrin, if you would monitor the chat and respond to those questions as you can. And so thank you, everyone, for staying with us. And now I'd like to welcome our case presenter, Dr. Raisada. If you would please walk us through this case today.
Sure. Can y'all hear me okay?
We can, thank you.
So my name is Miles Rosada. I'm a physician in Texas. I'm actually an emergency medicine physician, but I do have an addiction clinic in the Denton area. Our clinic, we see a lot of patients throughout the years. We don't have too many patients that are pregnant, but we do get them from time to time. And so there's some complexity with these patients that make them a little bit more challenging. And so I don't really have a huge question to ask today, but maybe more of a review of things to consider when we do have pregnant patients that have opiate use disorder, which is one of the main things that our clinic treats. This patient was from several years ago, but it was a 19-year-old female. She was currently 10 weeks pregnant. She was a G5P3 previously, and she used daily heroin. She did have a vaping pen that she used pretty much continuously, and she did admit to intermittent THC use and marijuana use. And she actually presented to us and was calling for bad abdominal pain and was wanting pain medication, hydrocodone initially from our clinic. And so she was also complaining of some cellulitic lesions on her arms, which were near her injection sites. For the mental health symptoms, she had been diagnosed with anxiety, depression in the past, and she's been on medication and felt somewhat stable with that. She wasn't currently suicidal, but she has had suicidal attempts in the past as well. She did admit to having some trauma, an abusive relationship previously, but said at this time that that person was not in the picture and that she felt safe in her environment. And so Section 2, current and past substance use, I did mention nicotine. She's been vaping pretty continuously, and then the intermittent use of marijuana. For her behavioral health diagnosis, we put opiate use disorder, we put severe. She actually had issues holding a job or being involved with her family, wasn't able to participate. She said that CPS had taken away her kids previously, and so she's had a severe issue with opiate use disorder and being able to participate in society in a productive way, and it's been a big challenge for her. We also give diagnosis of cannabis use disorder and then anxiety, depression, but that is well controlled with her medication. For previous behavioral health treatments, she's had counselors in the past. Due to her income, she was eligible for a lot of state funding, so she didn't have to go out of pocket. But she has fired multiple counselors, multiple organizations that have tried to help her in the past. She said that they weren't a good fit. And presently, she is seeing a counselor in our clinic at this time. She's also tried methadone in the past, and she didn't really like going to the clinic on a regular basis. That was a very big challenge for her. She didn't have reliable transportation, and she relapsed multiple times. And with us, she was on Subutex. She said she was allergic to Suboxone. She was on Subutex initially, and actually today she's on Suboxone. She has gone to support groups infrequently in the past, and she currently also has a peer from our organization assigned to her that's helping her out. For Section 5, risk reduction services, we did give her overdose prevention education. All of our patients get intranasal Narcan mailed to them. And then we initiated Subutex while she was pregnant. But like I said before, she's been since transitioned to Suboxone. For every patient, we check the PDMP aware system. So we see if they're getting medications from multiple places. I usually will ask patients, I think it's kind of funny to, uh, if they are taking Suboxone from the street, how much they buy it for. So I just get an idea of what the street value is of those drugs, or how much they spend on Norco tablets, or what they spend on their heroin use. And it's pretty interesting to see kind of these secondary markets. Currently, she's on buprenorphine, sublingual films. She takes 3 a day, and she's currently still on citalopram. She has some cellulitic infections on her arm, and she was on clindamycin for that. She's no longer on clindamycin. And then previously, she'd had C-sections, an appendectomy, and then multiple abscesses that she said were bad enough that she had to go to an operating room and have a general surgeon do incision and drainage and packing and getting wound care. And so just in general, this population can be really hard to get appropriate care and follow through on their care. When this patient had talked to us, she was complaining of a lot of abdominal pain, and if she's pregnant, she hadn't had an ultrasound, she's had abdominal pain. There's a lot of things to consider. And so we actually had her go to an urgent care, which they referred to an ER. We went to rule out like an ectopic pregnancy, make sure that the baby was in the right spot. They did do an ultrasound in the emergency department, and she had an intrauterine pregnancy, and they could see a heartbeat on her. She also had a few of the sites on her arms cut open by the ER physician, let open to drain, and she was initiated on clindamycin. And then she followed up with our clinic, and we had recommended that she start prenatals, and then we talked to her about testing for different things that she could be at higher risk for, like STDs, HIV, hepatitis. These are things that are sometimes already checked for pregnant women, but we told her due to her heroin use that she's going to be at a little bit of higher risk. And so we wanted to make sure she could follow through and emphasize the importance of testing for things like HIV and hepatitis. Initially, she was actually resistant to treatment. She wanted call our clinic and ask for hydrocodone prescriptions, which we don't even prescribe to patients. And so we wanted to start her on Suboxone, but she was really not open to it. She said she'd had bad reactions in the past, and so we kind of negotiated with her. And initially, we kind of all kind of met on the level. We start her on Subutex, do initiate Subutex, and see how that went. And she was more open to that. And so neither side really got what they wanted, but we met in a good starting point, I think, for this patient. She ended up having a baby who did well, very little presentation for like neonatal abstinence syndrome. Patient was transitioned to Suboxone after her delivery, and she is right now in our clinic stable on 24 milligrams of Suboxone films daily. And so I just wanted to emphasize that because of her use and being pregnant, there's another person to consider. We recommended frequent ultrasounds throughout her pregnancy, more than normal, just to make sure the baby was growing appropriate size and developing normally as well, because these patients are going to be at higher risk for developmental abnormalities and introducing bloodstream infections and endocarditis and things like that.
Thank you, Dr. Raisada. From your main question on your form, it seems that your concern is not just to address the substance use and her mental health, but also her overall physical health. And so to help the learning community and just to provide a little bit more information, can you tell us anything about this patient's support systems? Are there any in place? What about wraparound services that have been provided to her? I know that you mentioned a bit about custody of her previous children in addition to or as a result of some of her substance use problems, but I also want to encourage our participants to ask their questions or provide insights about this case. You can unmute your microphone or drop those questions and comments into the chat.
This case was from a few years back. I did review her notes before I filled out this form, and I had written there that she was living with her mother at this time, that she didn't have any custody of the kids. I think her mother had custody of maybe one child, but she wasn't supposedly having custody of any children at the time. Today, she does have custody of her children, so she has definitely improved overall her situation. I think her mother was her only support system, and then we offer services like peer support. We have counselors, MAT providers, and stuff like that on staff. We have a lot of people in our clinic that can help with set up things like getting resources to talk to someone about housing, about signing up for Medicaid. Those are other types of service that we offer to this patient population, which still, even though we offer it, it's hard for them to want to do it. Sometimes they just don't want that help, or just are not good at following up on getting the care they need.
Thank you for that additional information. And as I mentioned earlier, I'd like to encourage our participants to ask questions or provide insights about this case.
One question we as the hub members had was screening for trafficking. She's been pregnant quite a few times to be so young. And we were curious when her first pregnancy was and if she has been screened for trafficking.
I think her first pregnancy was when she was 14 years old, so she was definitely very, very young. The guy that she got pregnant with was around the same age, and so I think he was like 15 or 16 years old. And so I think trafficking is always a consideration when you see lots of pregnancies at this age. We didn't have a super high concern about it because it was with I think the same gentleman had gotten her pregnant all these times, and he was a similar age. Usually, I'll see more of an age discrepancy if I'm starting to get really concerned about some type of trafficking. But they seemed like, and I didn't meet this gentleman as well, but from that situation, it seemed like they had years of experience together. It's definitely good consideration.
Yeah, I'm so glad you brought that up, Dr. Humphreys, because that did come up in our hub discussion. Another thing that came up, and sorry if you mentioned this, was this a planned pregnancy? Because that could certainly shape her experience moving forward, or if you know if it was planned.
I don't know off the top of my head if it was planned. I think my suspicion is that it was probably not planned. I think she'd had lost custody with previous kids. She's in a bad financial situation, unstable housing. So it's definitely harder to bring a child into that type of environment. So my suspicion is that was unplanned, but I don't know for sure.
Makes sense.
Dr. Ruiz has dropped a comment into the chat. I'd like her to allow her the space to unmute and make that comment aloud if she'd like to.
Dr. Rizada, I really appreciate how you're meeting the patient where she is at. You're acknowledging her challenges, respecting her trials, and giving her the evidence-based care and the compassionate care she deserves. With all these trials, it's very clear that she trusts her care team and continues to show up for treatment. And that's because you've been incorporating trauma-informed care. So I just want to recognize that.
Very kind of you to say. I think I know you from undergraduate at Texas Tech. I think you were in classes together a few times.
Very nice.
Yeah.
I agree. I thought that was really a special connection that the patient must feel to continue to come back into care. I think that is so valuable that you pointed that out, Dr. Ruiz. And patients have options, and if they came back, that means we're supporting them, and hopefully, evaluating what their expectations are, and doing some quality of life screening and helping engage this young 19-year-old in taking steps forward. I kept thinking about like SMART goals, what's most important to her and what could be next steps for her, and not to get my cart too in front of the horse. So I'll leave space for other people to share their thoughts.
Dr. Rosada, I was curious. I know your question was specifically about like screening and things like that, and this isn't necessarily screening, but in somewhat about fentanyl testing. I know in the Austin and Waco area, we've had a lot of heroin with laced fentanyl. And you'd mentioned in the past you'd had some difficulties with the Suboxone and things like that. And we found that sometimes that's because there's fentanyl in the heroin that causes some complications. So I was curious if y'all have done additional testing on her urine to see if there's fentanyl in there and if that could potentially be contributing.
So we do fentanyl testing now. At this time we saw this patient, I don't think fentanyl was something we talked about or discussed as often as we do today. So I don't believe at the time we did not do fentanyl testing, but it is something that we do now on a lot of the patients. I think since it's become such a big issue.
Dr. Rizal, I wanted to second Dr. Ruiz and Dr. Subrin for what they mentioned about your presentation. It was phenomenal, I have to say. I haven't heard many individuals or physicians out there with not necessarily psychiatry training who were so compassionate to take care of patient in a very holistic way. So I very much appreciate that. I was also wondering what city or where are you actually located, like exact location to actually be able to refer our patients over, because they keep moving from like one city to another, especially our methadone Suboxone patients. That was my one question. My second question is, how long, like how many worth weeks or days do you give of the Suboxone, or if you guys do methadone as well, if it's just Suboxone? Is it a week, 2, or 30 days altogether?
Yeah, so those are all good questions. So our we started our clinic in Denton, Texas in 2020, March of 2020, which probably we say is the worst time to ever start a business, our clinic. But we started doing telemedicine right away, and that really took off. And so we actually have patients in El Paso, Amarillo, Lubbock, Corpus Christi, Brownsville, any city in Texas, you name it. We have thousands of patients all over Texas. So we're able to see patients on uh, no matter where they're located. And so that's been a really unique thing for our practice. Typically, when we see patients, it just depends on their use. If they've been stable on a medication at a known dosage that seems reasonable for a long period of time, we may just continue it. If they're new, we typically will do usually half a week or 1 week at a time. And so we'll just try this, dosage of Suboxone, come back in a week and see how you did. Do we have any cravings, withdrawal symptoms? What are you feeling? And then we can adjust it week to week. And so we'll go from every week and then every 2 weeks and then to once a month. And that usually takes around 2 to 3 months to transition to once a month. So we don't just jump right away to once a month. Well, we start with a smaller dose initially.
And is that typically for only Suboxone, or you guys also do methadone?
So we don't we have to be an OTP to do the methadone. And
Right.
so we don't have an OTP at our Denton location. And so
Sure.
I would say that we only do Suboxone in our clinic. And so because we're able to grow, we're able to mail Suboxone to patients all over Texas. And we have good relationships with pharmacies that are able to get it overnight to patients and have them sign for the prescription.
Okay. That's great. That's awesome. Thanks for sharing all of that.
Yeah.
Dr. Rysada, we just had a question come in through the chat from Artisha Browder. Do you know if this patient was ever referred to a home visiting program?
I don't know off the top of my head if they were referred to that. I know today they're, like I said, this patient is like has a job, is with their family, very stable, has not taken heroin in quite some time. And so but I'm not fully sure if they were had a home visiting program.
And as we wrap up, I'll read this final comment from the chat. The best thing that came out of the pandemic, from Helen: permission and continued use of telehealth for mental health counseling and medical treatment. Absolutely. And that's one of the reasons we're all here today. Thanks, everybody, for your participation in this case presentation. We'll move to some brief announcements now. We'll continue to take comments and questions in the chat. Again, you can access the chat feature by clicking on the speech bubble icon in the Zoom toolbar. Thank you, Dr. Raisada.
Sure.
To receive credit for today's session, participants must have an active account with the Texas Tech University Health Sciences Center Office for Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that's provided in the chat or on the instructions on how to receive credit document that's been posted to the Content tab on iEcho. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation. For specific questions about CME credit, please email or call the TTU HSC CME office. And let us know about how we're doing by completing our evaluation. You can scan the QR code, which is on the screen, or click on the link that's being dropped into the chat. The evaluation will be available until 11:59 p.m. on September 15th. If you already have your account set up with the TTU HSE CME office, you can use the text in attendance feature with the code 39935. The text code is only available today until 11:59 p.m. Do you have a difficult case that you or your team have encountered? Well, let's tackle it together by bringing your challenging or complex case to the Maternal Health Echo. You'll get support from a team of experts and fellow providers. There's no need to prepare a formal presentation. It's as easy as what you saw today. We'll provide a case form for you to fill out to assist with your case presentation, and you can email us at cstat@uthcsa.edu to present that case. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at cstat.uthcsa.edu/contact us, and we'll be pleased to help you. That information is also in the chat. And we're also excited to share that the Center for Substance Use Training and Telementoring, or CSTAT, by Be Well Texas, is accepting applications for the opioid use disorder mentoring program. Join us for an exclusive opportunity for prescribers to receive personalized, one-on-one mentorship to integrate the MOUD services into your daily clinical practice. This exclusive offer is available to a select few in the Texas Public Health District Region 8, so don't miss your chance. To take advantage of this amazing opportunity, simply visit the application link that's on the screen and which will be dropped into the chat, or reach out to cstat@uthcsa.edu with any questions you may have. The Texas Perinatal Psychiatry Access Network, known as PeriPAN, is designed for clinicians who see pregnant and postpartum women, and PeriPAN was created to address the maternal mental health crisis. Mental health conditions are the most common complications of pregnancy and childbirth, affecting 1 in 5 perinatal women and ranking among the leading causes of pregnancy-related deaths. Lack of access to care and provider shortages further compound the problem. PeriPAN has 4 major components, as you see on this slide. We provide clinical guidance to help with a single patient case or enhance mental health care in your practice as a whole. As you can see on the map of the next slide, PeriPAN is anchored by 12 regional medical schools and health-related institutions across the state of Texas. Signing up is easy. You'll reach a mental health expert by phone and can consult with a reproductive psychiatrist within 30 minutes of your request or at a callback time of your choosing. Anyone in your office can call or text to start the consult or request. Each region has their own unique texting number, which will be provided at sign up. And to sign up, you can call the number on the screen. We would love for you to join us at the PeriPAN webinar series, which is held on the 3rd Tuesday of each month. These sessions complement the ECHO series, offering deeper insights into perinatal mental health. On the screen, you'll see a list of upcoming topics and dates. Be sure to register in order to stay informed, connect with experts, and expand your knowledge. We look forward to seeing you there. On the next slide is a list of topics and dates for the upcoming lunchtime maternal health echoes, which are held on the 1st Tuesday of the month. We invite you to join us in all future sessions to continue learning about these important topics and to engage in meaningful discussions that support perinatal mental health. And before I wrap up, I welcome Dr. Anastasia Ruiz to provide our session summary and case recommendations. Dr. Ruiz.
Yes, do you have on the PowerPoint, Brenda?
No, just our final comments on the case in the session.
Oh, perfect. Yes. So, thank you so much for the presentation. The summary here are a few things that everyone that's patient facing has impact to the patient. And it doesn't just take the physician, it's everyone that is in contact with the patient's case. Another thing I do want to mention is that pregnant women also have a lot of physiological changes during their pregnancy, including increasing more blood, and that can dilute their medication. So when our patients in pregnancy or postpartum are telling us about changes, um, we need to recognize that and adjust our medication frequently and appropriately, and continue to give them that compassionate care. And last but not least, follow up. So keep checking on your patients because sometimes they may have no one else but their care team. So thank you so much.
Thank you, Dr. Ruiz, and thank you all of you for joining today's Maternal Health Echo. We extend our appreciation once again to Dr. Joy Subrin for this presentation and Dr. Rysada for their parts in today's presentation. As a reminder, to earn CME credits, please complete the evaluation using the link that has been provided to you in the chat. If you have a case or scenario you'd like to share, please email the CSTAT team. And we look forward to seeing you at our next session on Tuesday, October 7th at 12 p.m. Central Standard Time. Have a great rest of your day and enjoy these extra 4 minutes. Thanks, everyone.